We're about 2 minutes past the hour, and we should get started. My name is Dr. Bill Hallman. I am professor and chair of the Department of Human Ecology at the School of Environmental and Biological Sciences, and I am one of the team of leaders of the Science Communication Initiative. Thank you all for joining us, and thank you very much to our speakers. For those of you who are not yet familiar with the Science Communication Initiative, or this is the first time you're tuning in, we have a long history at Rutgers of being at the forefront of research, teaching, and practice of science, health, risk, and environmental communication. We have put all those together under the rubric of science communication and have come together as a group of faculty from really across Rutgers to put together a science communication initiative designed to advance science communication across the university. One of the outputs of the initiative is this series of seminars or webinars. And so I'd like to welcome you to the first of our spring seminars, where we will be talking about COVID-19. All three of our esteemed speakers have lots of things to say. So I'm going to bow out of the picture and turn it over to my colleague, Nick Ponzio, who will serve as today's moderator. Nick?
Thank you, Bill. And let me add my welcome to everyone for joining us this afternoon. We have three great speakers on the topic of ongoing and emerging challenges regarding effective communication about COVID-19 vaccination. And my role as moderator, I will just let each of our speakers introduce themselves. I'm in the Department of Pathology, Immunology, and Laboratory Medicine at New Jersey Medical School on the RBHS Newark campus, and another of the leaders of the Science Communication Initiative. So without further ado, let me introduce three speakers: Katherine Ognyanova, Halkitis, and Itzhak Yanovitzky. So if each of you can just say a couple of words about yourself, where you are, and then we'll jump into the meat of the program.
Hi everyone, very nice to be here. Thank you for inviting me. My name is Katherine Ognyanova. I am a faculty member at the School of Communication Information. I study generally network science and social influence in political and civic behavior. More recently, me and my colleagues have refocused to study policy and attitudes towards COVID-19 using survey and social media data. And so this is what I'll be talking about.
And I am Halkitis. I am the Dean of the School of Public Health at Rutgers, located in both Newark and in Piscataway. I am a public health psychologist and infectious disease epidemiologist whose work is primarily focused on HIV, HPV, and other sexually transmitted infections, but whose life has become consumed with COVID-19 in the last year. Thank you for having me.
Everyone, Itzhak Yanovitzky, Professor of Communication at the School of Communication and Information here at Rutgers. I'm contributing to these initiatives. I'm also, together with Bill Hallman, representing Rutgers on the Standing Committee of Science Communication National Academies. And I'll be telling you a little bit about the effort that's being done there to improve communication around vaccine hesitancy and the vaccine rollout.
So thank you very much. And we're going the order of how the speakers introduce themselves. We're going to have a Q&A, but it'll be at the end of all three talks. So hold your questions until then. And then you can put them in the Q&A box at the bottom of your screen. So Katya, we'll kick off with you.
Awesome, thank you. The mandatory screen sharing. Second to do this properly time. Hopefully people can see the slides now. And I think the organizers have also sent those to you so you can look at your own copies, or they should be available afterwards in any case. So as I said, I have been over the last year or so part of this large-scale research initiative revolving around COVID-19 policy and COVID-19 attitudes. The name of it is the COVID States Project. And the interesting thing about it, and you can find all of our reports and things about us on covidstates.org. The interesting thing about it is that we're collecting large-scale survey data on a state-by-state basis. So we have data for all 50 states, and we have survey waves of about 20 to 25,000 people every month, pretty much. We're on wave 15 right now. We've been studying a variety of things, including the prevalence and spread of the disease, but also how people react to and adhere to various health-related guidelines, whether they're wearing their masks, socially distancing, what kind of information they're consuming, and what kind of misinformation they're seeing and their misperceptions based on that. We're also focusing quite a bit of attention on trust in institutions. So who is it that people are trusting to get information and to help them out with the COVID problems that they might be experiencing? This is a joint initiative between Rutgers, Northeastern University, Harvard, and Northwestern. And in addition to the survey data, we also collect quite a lot of social media data. So we have some of that in our data set. So what I wanted to talk to you about today is on the topic of vaccines and challenges related to vaccine messaging. We actually have a couple of reports coming up that will be published on our site tomorrow that are using our latest data wave collected in December and January. That has about 25,000 people from all 50 states. And that focuses quite a lot on the question of vaccines, as it is right now probably the primary concern of all of us who are trying to see what useful information we can get around the subject of COVID-19 that might benefit us all. And so a few results from our research in that realm. So one thing that we have been tracking over time for quite a few months is people's hesitancy and resistance towards vaccination, towards COVID-19 vaccines. So we were using items that asked people how likely they were to get vaccinated, but then we realized that likelihood is not telling us all that much, and that we should be asking whether people wanted to be vaccinated right away or whether they wanted to wait a little bit to see what would happen when others get the vaccine, or whether they were saying that they would never want to get vaccinated. So the item that we used in our last survey actually asks those questions, and we see that about 23% are the vaccine resistant people, and then we have about 40% or a little over that are vaccine hesitant, in that they won't get vaccinated as soon as possible, but they want to wait a little bit, see what happens, and then make up their minds. And we see that when we compare the likelihood, how likely you are to get vaccinated, to the timing, we find out that people who say that they're likely to get vaccinated, extremely likely, those are the predominant group that says as soon as possible. And then the hesitant group are the ones that they say they're somewhat likely or neither likely nor unlikely. So we learned how to interpret those items that are based on likelihood when we looked at how they compare to the timing of vaccination. We also did breakdowns of hesitancy and resistance. Yeah.
Your slides are not advancing.
Oh, shoot. Huh. I apologize for that.
There you go. Thank you.
Thanks for letting me know. Okay. This is the likelihood of vaccination. I wonder why that didn't work. Apologies for that. So we are all the way up to discussing how vaccine hesitancy and resistance break down by various demographic parameters. And as we all know, race is a huge determinant here, where because of history, and persistent inequalities in access to healthcare and issues with healthcare. African Americans are especially resistant to vaccines. And so that's a challenge that we all know about that we'll have to overcome. We also find that women are both more hesitant and more resistant to vaccines. So they're more likely to be unsure about whether they want the vaccine and when, and they're also more likely to be resistant to it compared to men. And this is also something that we know from previous research. There are similar kind of differences that are expected from past research in age. We can see that people from the older age groups that are especially affected by the pandemic, they're not very hesitant or resistant. And then younger people, they are more hesitant because this doesn't seem that much like it applies to them. In previous surveys, we found that young people think that they're not at risk for COVID. A lot of them think that they're not affected at all by this problem by the pandemic.
I'm sorry to interrupt again, but the slides are not advancing.
Sorry. Now?
Yes.
Okay. I will try and click twice each time. Okay, so as I was saying, so young people are more hesitant. That's probably because they think they're not at risk. And then, as we know, Democrats are the most enthusiastic about the vaccine, Republicans and independents less so. So there's a partisan element there as well. We've looked at vaccine resistance and hesitance by state. This map is showing you that. I'm happy to report that New Jersey is one of the states where we have the least vaccine resistant population. We're number 5 from the good side down. So the fifth lowest for vaccine resistance, with 17% of the population saying they didn't want to get vaccinated. What is said is that 17% of the population is actually a good thing compared to other states. So it's still a pretty high number. I will skip a couple of slides in the interest of time and just show you briefly a few findings on vaccine misinformation. There are several statements that you might not have seen if you don't go to the dark corners of the internet floating around about the COVID vaccine that say things like that it will alter people's DNA, that it contains microchips that could track you, or that it includes some kind of tissues from aborted fetuses. Those are all misinformation items that had made the rounds over social media. We have one item that is correct in there, mixed in there, that says just that the vaccines were tested on thousands of people in clinical trials. That's the accurate one. The good news in looking at whether people believe those things is that a relatively small percent of people actually believe the misinformation items. The bad news is that a lot of people say that they're not sure. So instead of saying that, you know, those are clearly false, you have, for example, on the item about using the fetus tissue in vaccines, there's like 37% of the people we polled who said that they weren't sure if that's true or not, which is kind of disturbing. We find differences in the misinformation levels depending on various demographic groups, as before, as with other things that we discussed. And you can see that, unfortunately, African American and Latino respondents are more likely to believe misinformation items. So that is problematic. They're also less likely to believe the actual correct information saying that vaccines were tested on thousands of people in clinical trials and that they were safe. Hopefully the slide has switched to the next one that shows that Democrats are less likely to believe misinformation items than Republicans. We also have one that is based on age. And you can see that the age group of 25 to 44, so not the youngest and not the oldest group, they're most exposed to that misinformation. And we find that when we do a deeper dive, that a lot of that misinformation targets young parents with children. So if you look at young parents with children as a group, especially women, but women and men both who have children, that they're more likely to believe vaccine misinformation about COVID-19, which is problematic, and they're less likely to believe that the vaccines are safe. The last thing that I quickly will go over has to do with vaccine communication strategies. So we ran a couple of experiments to kind of test out people's reactions to various strategies of kind of telling them to get vaccinated. And so there were two things that we were looking at. One was messages and the other one was messengers. So in terms of messages, the messages that we tested in this experiment were in addition to the control, which simply asked them how likely they were to get vaccinated. We stressed vaccination as a matter of patriotism and doing what is right. Vaccination as a matter of preventing harm to yourself and your community. And then we asked people if they would get vaccinated, if most of the people they know said they would get the vaccine, if most scientists recommended taking the vaccine, and then if their personal physician recommended taking the vaccine. And so what we found on the whole in this experiment is that pretty much all of the messages were pretty effective, especially the scientists and the doctors one. If your personal physician tells you, and if scientists tell you, that's a good thing, that actually helps. The one that didn't work quite so well was the patriotic one, telling people that it's the patriotic thing to do. It was kind of a little bit helpful, but not significantly different from control. So most of those treatments are doing a pretty good job telling people, giving them a message about why they should get vaccinated, especially the messages that have to do with doctors and scientists, but also the ones that have to do with their peers getting the vaccine. The last thing to mention before I wrap up is the question of messaging in terms of who is delivering that message. So in that experiment, what we did was we had different types of messengers in all of those groups. In the beginning of the survey, you ask people who their favorite politicians, favorite athletes, and favorite celebrities are. And then later in the survey, we piped those names in a question about vaccines. So we asked them if that person was vaccinated on TV or if they announced they got vaccinated, would that, make you more likely to get the vaccine? How likely would you be to get vaccinated? And in addition to those favorite people, we also asked specifically about Anthony Fauci, Donald Trump, and Barack Obama, those specific individuals. And what we found was that the messenger experiment was not at all doing as good of a job. Like, people were not as impressed by being told that that the celebrities or the people that they like or the politicians they like, that had a very small effect on resistance to vaccines, so it didn't help all that much. But what it did do is, for political actors, it triggered kind of a backfire reaction from people who didn't like them. So if you told Democrats about Trump getting vaccinated or Republicans about Obama getting vaccinated, that actually backfired on you and they reacted in the opposite way of what we'd wanted. And so our message here was that, yeah, maybe we use scientists and celebrities to promote this. They do no harm. They might do a little bit of good, though not that much. But we should be really careful with political actors and use them in a targeted way, because they might actually cause people to have the opposite reaction of what we're hoping for. And so with this, I will stop here.
Great, thank you. Thank you, Katya, very much. The next speaker will be Dr. Halkitis. Barry, thanks.
Thank you, and thank you for having me here. So I'm going to try to accomplish a lot of things here, but I do want to start by saying that I think it's critically important to think about this epidemic, this pandemic, as a work in progress. I think that every single day brings us new information as we're moving forward, whether it be about how the disease works or how it's transmitted or how our vaccinations are being rolled out. So, things are moving relatively quickly. So what I have to say today may not be true in a month's time. So we should just keep that in mind. I want to say number two also, to Katya's point, which I really enjoyed your talk, Katya, is that, people behave, but they don't behave out of context. So there is a culture and a context in which people navigate. And, you know, whether that is a political context or it is a, you know, a neighborhood or it is a cultural context, that shapes how people behave. And so that's a lot of what I'm going to talk about today. And just do an overview of where we are with the vaccines and then think about how we're moving these things forward. I have also been actively involved in the last year in lots of different aspects of COVID-19, including the creation of the COVID-19 contact tracing program for the state of New Jersey, and then my own research on life experiences of HIV positive individuals through the COVID-19 pandemic. It's very complicated. It's not clear if there's protection. There seems to be this weird cytokine interaction right now that's causing people's positive people's platelets to like diminish. It's a really, really strange time in the HIV world. A good time, but a strange time with COVID-19. And then also a large scale antibody assessment of using time-based sampling in Newark, looking at exposure to COVID-19 by recruiting people at like supermarkets and bodegas and big box stores, trying to get a better sense of what the pandemic potentially looks like, recognizing the shortcomings of antibodies. And then last but not least, a very large scale national study that we enacted over the course of the spring and the summer on experiences of LGBTQ people around COVID-19. So lots of different aspects of the work. But where are we today? So let me see if I can do this correctly. You're seeing my slides good? Is that okay? Let me actually put it on slideshow and you can see even better. And there we go. So the state of the pandemic. And so where we are right now is fortunately in the last few days in a better place than we were a couple of weeks ago. We saw the Christmas, Hanukkah, Kwanzaa rush of like infections when people gathered. We've seen a decrease in cases, a decrease in deaths, and a decrease in hospitalizations over the course of the last week or so, which is a step in the right direction. We may be coming up for air, but there is no doubt in anybody's mind that at the rate we're going, we will be at 500,000 deaths by the end of February, if not sooner than the end of February. In the state of New Jersey, the pattern is consistent that with the rest of the country. We know that there's a total of about 20,000 confirmed deaths and about 600,000 confirmed cases. So what are we going to do about managing this disease? We spent a lot of time talking about behaviors, about mask wearing, about washing hands, about physically distancing with each other. You know, vaccination is another behavior that we're going to enact. And just like mask wearing, and just like washing hands, and just like physical distancing, vaccination uptake requires that human beings act as rational operators. And we know that human beings are anything but rational operators. And so we're going to have to think about all of the stuff that Katya told us about hesitancy and all of the emotional and psychosocial factors that drive people's behavior to continue to try to get vaccination to a point in our country where we have about 200 million people vaccinated. Without that, we don't get to herd immunity. And quite frankly, I don't think we get to that point of 200 million anytime before the end of the summer. The vaccines, people will say it's our biomedical intervention. I always laugh at that because I'm like, yeah, sure, but they require behavior, like exercise and like wearing a mask, and that people need to do this. The vaccine doesn't just float down from the sky into somebody's arm and all of a sudden it's there. And so thinking about how the behavioral components married with the social and structural and political that Katya talked about, married with the biomedical come together is going to be really key in trying to move this forward. Where are we? So we've got 2 vaccines right now. We've got the Moderna vaccine, 2 doses, 28 days. The Pfizer vaccine, 2 doses, 21 days. Johnson & Johnson will be heard by the FDA momentarily, probably available by the middle of February. It's a 1-dose vaccine. AstraZeneca is potentially a problem. The EU yesterday reported they are unlikely to approve it for age over 65, given the limited efficacy it has shown. And Merck just pulled its vaccines yesterday because of the lack of efficacy of those vaccines. So we've got 3 vaccines, which is potentially by February, which is better than 2 vaccines. We also have it in combination with the Production Act being implemented. And so vaccination is actually being created by suppliers. So hopefully, for those of you who are very patiently waiting, and I know you're very patiently waiting, because I keep getting phone calls from my friends and colleagues because they must think that I have vaccine in the trunk of my car that I'm keeping from them. They keep wanting me to hook them up. I'm like, no, It's like Studio 54 days, kids here. You have to just wait your turn and maybe you'll get in. But I think in 2 weeks' time, we will actually have sufficient vaccine that we will be able to roll it out to the populations that need it the most. But we are certainly at a standstill in New Jersey. And I don't want to just pinpoint New Jersey, because every state is going through this. And Governor Murphy and Commissioner Persicelli did their darndest to try to get us the vaccine. The problem is that they were blindsided by the federal government. So here's where we are with vaccines right now in the state of New Jersey. Let's say that by the end of this month, 500,000 people are vaccinated. Well, that means that at that rate, in the state of New Jersey, with people over age 18, we need 12 more months to get everybody fully vaccinated. So that means the fall, before we have the majority of people vaccinated. I am hoping that this number of 500,000 will become larger, and that 12-month window will become a 6-month window. But then again, that really will depend on the availability of vaccine. You will see at the bottom of the chart there a breakdown of vaccination by gender. Females right now currently much more likely to have been vaccinated than males, and not surprising to anyone here, given the health disparities that we owe. Like, why was anybody shocked that Black and brown people were dying at higher rates from COVID-19? Why did this act like a huge surprise to anyone when Black and brown people suffer health disparities across every disease state? Right? So we were like, oh my God. No, not oh my God. This is exactly what was going to happen in a society that doesn't have social justice and health equity. And we see it here with the vaccination also, with close to half of those people who are vaccinated mostly being white. So there's a disparity there also. So here is what I got in the mail from the state recently, because I am in the 1B group. You are eligible to get the COVID-19 vaccine. However, due to supply limitation, vaccination point may be difficult to forget. So we ask for your continued patience throughout this process. This is the frustration people are feeling. I'm hoping we will be able to get through this quickly so that people who actually are motivated, and there are a lot of people who are motivated to get the vaccination, don't lose that motivation. Okay. Right now in our state, as we know, there's a COVID vaccination registration site that I actually think is pretty good. The problem, of course, is for older adults, such sites are very complicated. And so what we need to think about, and what I want our communications people, our experts to think about, is how we message this to older adults. You know, I've got a phone at 58 years old that I guess I know how to use, but if I was 14, probably would know how to use a lot better. And so I think thinking about how we continue to message to older adults, how we help them being able to register in a way that is amenable to them, that is helpful to them, that doesn't depend that they navigate some complicated system, is really, really going to be absolutely key. I think about this commercial I see on TV all the time where a young girl who's going to her foster mother talking about breaking up with this young man and saying that he tagged her, and the foster mother says, well, I can cut out those tags, right? And you know, the daughter saying that's not how tags really work. So I think in that joke is a reality of where we are with the sort of literacy of people around e-technology. As I said before, we are in phases 1A and 1B right now. I was very happy when Governor Murphy and Commissioner Persicelli, along with Governor Cuomo from my home state of New York, decided to open it up, because I think what was happening is that we were sort of like waiting in line for everybody in 1A to get done before we moved to 1B. And my whole metaphor for that was, that's kind of like being on a ship that's sinking and saying to people, you got to fill up one boat first before you do the other boats, right, to get off the boat. That's not the way to work. We need to open up more widely, and that's what happened. As a result, unfortunately, because I'm going to say it, the Trump administration lied, there wasn't enough vaccine to do that. Had we known that, we might not have opened it up so widely, but who knew at the time? So Fauci says herd immunity could require nearly 90% of the population to get vaccinated. Now that Dr. Fauci can actually speak again, we'll probably be getting a lot more facts on a real-time basis. I think 75 to 80% is probably more realistic, and that will get us to the herd immunity that we need, given the fact that there are some people like me who had a mild version of COVID-19 in March who has this persistent antibodies, right? So that combination with the vaccinations should get us to a decent point. This is a chart looking at a Gallup poll and building on Katya's work about vaccination hesitancy. And fortunately, we have seen an uptick in the willingness of people to receive vaccine. I think that as you change culture and as you change messaging, and as you have a leader in this country who is consistent with the leader in our state, you're going to see much less resistance. There will always be people who are not going to take the vaccine, always, but those people have always existed. We also see this consistent pattern, not only across the population, but across numerous demographics, including age, race, gender, education, party, and income, right? Even the Republicans and people who are leaning Republican have shown an uptick in their willingness to take the vaccination. Of course, there is the opposition, there's the anti-vaxxers, there are people who are resistant to anti-vaxxing, and this is a really wide phenomenon. And, especially in social media, and what we're in one study that was found and that was published, they tracked 425 accounts on Facebook, Instagram, YouTube, and Twitter, and showed that 59 million followers, there were 59 million followers for those particular accounts. And there had been, all of these posts about anti-vaccination just simply during the month of June, right? So there is a lot of misinformation out there that is unfortunately not being regulated. Okay, let me keep going here. So mythologies drive vaccination opposition. We know that perfectly well. We need to understand that we are in this battle, and we need the best tool I think we have is to just continually put out the correct messaging. I've spent way too much of my last few months doing news programs, but I do it because I think that the information just needs to be heard over and over and over again. And the more we repeat it, the in better shape we will be in. Okay. So finally, I think the other challenge we face is that we have a healthcare profession where not everybody's so willing to be vaccinated. And we know from studies that have been published during this year that nurses express much more vaccine hesitancy than doctors. As Katya said, women more vaccine hesitancy than men, although based on the New Jersey data, the vaccine has been taken more by men. People of color, not surprising, given the medical mistrust and mistreatment of people of color throughout the course of the 402 years in this country, are more hesitant. One half of all healthcare workers in 17 Riverside County refuse to be vaccinated. That is a problem. So if the people who are actually delivering the care are hesitating to actually receive the vaccine, then we have a struggle to get those who are not healthcare providers to actually believe in the vaccine. So I think we have a lot of work to do here on multiple fronts. So, but what do we need to think about moving forward? And this is going to be the wrap up of my talk. I think first and foremost, the future holds. I'm thinking about how we improve things and how we move forward. Realizing our national strategy. We have a strategy now. For those of you who don't know, it was not until Obama and Biden in 2010 that we had a national HIV strategy. That just took like 30 years. But fortunately, Biden, is learned from that, and he came in with his national COVID strategy. So we have a strategy right now that is real, investing in immunization and enrolling providers and community outreach, which I think is a really, like the HIV plan, really thinks about COVID-19, not from a purely biomedical perspective, but from a biopsychosocial perspective. And that's how we need to think about this disease and every disease. Number two, we need to think about the ongoing role of responsibility and altruism, right? What role do we as human beings have? There are personal responsibilities we have, and there are shared responsibilities. And I have spent the last few months talking about my own personal responsibility and my commitment to my brother. And I say to people, if you are struggling with mask wearing, and let's face it, nobody loves wearing a mask every day, right? This is so reminiscent to me of my work in AIDS in the 80s and 90s. Nobody wants to wear a condom every time. It's the same thing, right? But we do it because we care about other human beings. And for me, the story I always share is about my brother, my younger brother, who has MS. The last thing I want to do is transmit COVID-19 to him. And so think about the person you love the most and enact your responsibility towards that person and towards your humanity at large. Number three, we need to normalize health behaviors. We need to make it normal that it is vaccination is part of our fight against this disease. So we need to create habits, we need to identify the environmental constraints, we need to build knowledge, and all of those things in combination can get us to a point where we change behavior. Unless we change people's habit and automatic processes, unless we change the sort of false narrative that exists around COVID-19, the degradation of science that has existed in this country for 4 years and more, right? Unless we make it easy to get the vaccine, which is take it to people, don't expect people to come to you, right? Then we're not going to be actually able to get to the point where we're actually enacting this behavior automatically. Building trustworthiness, expertise, and acceptability are key. Means that we have to target very specifically certain groups that are less likely to be vaccinated, and thinking about what are the strategies we use with those populations to get them to trust, right? And the fact of the matter is one size is not going to fit all here. How we build trust in 65-year-olds may be different than healthcare providers, may be different than Republicans, recognizing that, of course, that people hold multiple intersectional identities, of course, but that one, just like we would not expect every teacher in a classroom to teach their students, every single student, with one method, that there are multiple methods. We need to use multiple methods, multiple adaptive strategies for interventions to increase hesitancy. And this is just another example, just showing again about the trustworthiness and the concern that people have about side effects and what have you. But again, I have been doing work on HPV vaccination in young sexual minority men. And let me tell you, there are concerns there and misinformation that have a whole generation of young sexual minority men who are not vaccinated for HPV and who are exposed to virulent strains of HPV, because somehow we dropped the ball on that. Number 5, debunking myths and respecting science. So I think that sort of says it all, right? And so, making sure we put the facts out there and making it clear to people with a recognition that we need to say things many, 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 many times in order for the message to become clear. So here are just some 10 things, that I wrote in this editorial that came out in the Hellenic News of America last week that I'm happy to share the link with you, but just trying to put the facts here in as simple, everyday language as possible for people. And again, debunking this idea that somehow these vaccines were just invented overnight. The fact of the matter is that the scientists in the United States have been thinking about SARS since 2003. When the first SARS epidemic happened, and sort of disentangling how SARS manifests. And so these trials, which took place, yes, they were kickstarted for sure, but Project Warp Speed, which turned into Project Snail's Pace. But unfortunately, people just think that they were developed overnight. But the message has to be that we've been thinking about SARS for a long time, and then no shortcuts. There were no shortcuts to the testing. The FDA was really held the scientists, hands to the feet to the fire about making sure that the data were clear. And that's why Merck, for example, pulled its vaccinations. Learn from the past. I mean, how many times do we need to say this? I mean, the same thing, with the same battle we had with polio, the same battle we had with smallpox, the same battle we had with HIV. I wrote this article a few months ago, like lessons from HIV are very much like lessons to talk about COVID-19. The whole hysteria about bags at the supermarket so reminded me of toilet seats from the 80s. It was just like people's behavior has not really changed. Let's use the past to try to maintain the hysteria in the present. And then finally, I'm going to conclude by saying this is an article that I just got published about a new urban public health paradigm. I'm very proud to say that this new urban public health paradigm was selected by President Holloway to be one of the 6 presidential initiatives. My colleague Leslie Cantor and I developed this and have been working on it for several years. But I think ultimately our path forward for this or any disease or any health condition is to build programs around social justice and health equity that marry the efforts of clinical care and public health, and that bring to the table as equal partners the academic health system with government, with business, which knows how to do things a lot better than academia, and with the people who are most affected in the community at the table together, thinking about solutions. And this is the paradigm we're trying to implement in Newark and then provide as a model for the rest of the country. I leave you with these these links and what have you to follow me and to find our school. And it's been a pleasure speaking with you this afternoon.
Great. Thank you, Perry. Thank you very much. And last but not least, our Itzhak Yanovitzky will give his talk and the end of the program. Itzhak?
Yeah, thank you, Nick. I'm gonna put in
You're
the chat a copy of my slides so you can see that. Let me see if I can share my screen. Hopefully you guys can see that. Okay, awesome. All right, so thank you, Katja. Thank you, Perry, for setting us up. I think it was good to see, always good to see the data and look at the challenges we have. One of the things the national academies have been concerned about, and I was involved as Bill in some of this effort, has been exactly this national strategy. One of the things I think we realize is communication is really important in terms of, particularly because there's a behavior element involved here. And beyond education, we need to do some other things with communication. And some of the concern has been that there has been miscommunication about COVID-19, but there's also been very little coordination in terms of communication activities. There's many people communicating about COVID-19, but they're not very coordinated, and sometimes they're not really sure what they do. And so national academies came with this idea that if we have a national strategy to address COVID-19, as we do for opioids and some other, we also need to have a national communication strategy to some extent to coordinate this kind of effort. So they got together the resources of the national academies and the ability to convene experts and come up with working towards creating some sort of a document or guidelines in terms of how you communicate effectively about COVID-19. Now, what I want to do is I want to just give you a very brief overview. And there's a lot of links here that you can click on and follow and get all this information, all these documents. One of the things they've done, again, the same kind of concern national academies, of course, have about COVID-19, including issues of equity, including the issue of how to reach populations, including concerns about vaccine hesitancy and others. And so they've kind of been operating from this model. That's the model of increasing vaccination model. A lot of what you see here is what both Katja and Perry already covered. It's about what people think and believe. It's about also the social dynamics around it, like social norms, how much support, responsibility. All this issue is really important in terms of motivating people to get vaccinated, because motivation is going to be a key. We're not anticipating right now that it's going to be mandatory for people to get vaccinated, even though some misinformation has been circulating about that. And of course, up to vaccination, you have all these intervening variables, right? The big unknown about this moving target that Perry already covered, such as vaccine availability, a convenient cost, service, quality. All of these are going to be important. So we need to look at all of this together in combination and figure how we address this with communication. In terms of challenges, I'm going to identify here, I think 5 or 6 of them. And again, my goal is to just highlight what National Academy sees as potential challenges around this issue. Many of the slides I'm going to show you here, the data is taken from the Kaiser Family Foundation monitoring program, so not very different from what Katja has presented. But number one challenge, of course, is vaccine hesitancy. One of the primary concern of the National Academy has been to do audience segmentation. We understand that different, as Perry said, different audiences need different kind of messaging and different kind of communicators. That generally, again, the segmentation here is not based on race or political affiliation, so forth, but rather based on the behavior. In terms of where you are, I mean, we always talk about in public health about meeting people where they are. So we clearly have about 34% here of people who are ready to get it as soon as possible. I did get the same email that Perry did, and actually did click through, and there's no way I can make an appointment anywhere, I can tell you that. So even though I'm thrilled I'm eligible, I cannot get a vaccine, but I'm ready to get one. So I'll be in that group. Then you have the group, the 39%, that these are kind of the wait and see. We see a lot of African Americans being represented there, right? They want some sort of confidence. They're really particularly worried about side effects, and they're more likely to take it if other people are going to take that. Okay, so they want to see that kind of social proof that's working. Again, there's a smaller group that will get it only if it's required. Again, talking about this kind of mandates potentially. And then there's a definitely not group, which is going to be very difficult to communicate with. So the idea of audience segmentation is really important in trying to push this idea of know your audience, know the different groups of audiences, and they have different information needs, and they have different means of influencing them. So we need to be conscious of that as we move forward with communication around hesitancy. Another one, Perry already brought it up, is equitable vaccine allocation. And clearly, there's some, I think you saw the data about that. You can see here some data suggesting that African Americans are concerned about equity issues. They don't believe or they don't have confidence that they will be prioritized. The same is true for Hispanic adults. Another issue here, which kind of both Katja and Perry brought in, is the extent to which we actually collect data about who's getting vaccinated. There's a concern in the last few days about whether we're actually collecting racial, ethnic data about people who get vaccinated so we can actually see who gets vaccinated. We clearly have that in the state, but that's not uniform across the board. There's a chance that we need to have this data to be able to communicate this information with these different groups. Challenge number 3, vaccine distribution. Okay, even though there's a lot of attention, there's been a lot of attention initially on vaccine hesitancy as the major problem. And now we realize that we may have some other issues that involve with, or that has to do with the distribution, particularly with so many people already willing to take that. And as Perry put that graph in, we see more and more people willing to be ready to take the vaccine. So, we're moving to a smaller proportion of the population that is vaccine hesitant here. Again, one of the issues that we have concern here, as Perry said, think about the elderly who do not get information from social media or not on social media. So again, the majority of public say they don't have enough information about when and where to get the COVID-19 vaccine. So part of what we need to do, not simply focusing on hesitancy, but really focusing on how do we make information available to people when we have this information about how to get the vaccine and where they can get that. And again, you see that the differences here is particularly acute for minorities, right? Hispanic adults and Black adults are more likely not to know what's going on, and we want to make sure that there's an information gap there that we need to close. And again, national academies want to point attention to that. Challenge number 4, that's going to be a big one. That's unrealistic expectations. Okay, so one of the issues we know that when you tell people something, you make them optimistic. I mean, I think some of you noticed today the media were all over President Biden because he said that he shooting for 150 million vaccines as opposed to 100 million, and then all the questions today in the White House briefing were about that. Why is he contradicting with Fauci? Why they don't agree? Why is the president overly optimistic? Is he misleading us? The notion here will be to manage expectations. And I think part of that being honest and transparent, and just as Perry being the introduction here when he said, whatever I tell you now may be not true tomorrow, and we need to be honest about that. And managing expectation can be important. Notice that 60% of the people here in the country are optimistic about that. And that's good. We want to keep them there, but what happens if we, again, overpromise and don't deliver? We know that potentially going to have an impact in terms of trust and motivation. Challenge number 5, misinformation. I think enough said, okay, but you can see here, I read this, the idea of state mandates. There's no serious consideration, at least not in a state right now, but this information is circulating that there will be a mandate. Some of this information is circulating about anti-vaxxers. And you can see that there's a great variation in terms of whether or not this will be acceptable. For example, clearly Republicans are less likely to accept a mandate. Not even if it's true, the fact that it's out there can be misinformation, can again influence their motivation to get the vaccine, particularly, as we saw that around masks and mask wearing as a political statement, as opposed to that. So that's another part of misinformation. So there's a great resource that I will recommend to everybody. It's very thoughtful, that consensus study produced by national academies. I have a link in my slide so you can check it out. But again, it's a framework for equitable allocation of COVID-19 vaccine. And what you see, number 4, points number 4, 5, and 6 here, really emphasizing this need for communication. and communication with kind of the big C, which means the national kind of communication, and we think about the ecosystem for communication that we have, but also the smaller C in terms of communities, specific communities and specific localities, and how we build capacity there to communicate effectively with individuals. And again, idea is that to have a campaign. We know that Biden administration is going to invest in a campaign, national campaign, to promote vaccination, and this whole element of evidence-based strategies, including communication strategies. That's why collecting data about public opinion, I think, is really important in terms of informing that effort. Now, what's going on in terms of, so here's a link to that particular report that I mentioned. In addition to that, in the spirit of rapid response, I think we increasingly realize that as scientists, we need to be able to respond rapidly to inquiries that we get from policymakers. So we need to support our governor, we need to support our public health department to do this, and that's what we're here for. One National Academies created that as a Social Experts Action Network, or SEAN, and you can see a link there. And again, the idea is to bring some of the leading experts in this country around communication, risk communication, and so forth. I think many of them were people that you know. And again, support these kind of activities or communication activities within that. So part of the things that Sean does, which I think is really interesting to many of you, will be that they actually have a survey archive that they put together. I'm putting a link here. So, if you're looking for Gallup surveys or, one place we can get a lot of survey about COVID-19 attitudes and beliefs, you can go there. That's a great resource. It's publicly available to everybody who want to take a look and make better decisions about communication that are based on data. You also have, they had a webinar that I would encourage you to see around COVID-19 vaccine confidence. There's a particular session there about equity. Again, engaging how to reach populations or underserved population with some leading experts. That video is available, as well as the other resources. It's worthwhile your time to watch it. I think a lot of us already participated in that. I can tell you that's forthcoming. I think it's going to happen this week, because I did see and respond to a draft of Sean's report that will focus on, again, this kind of strategies for building COVID-19 vaccine confidence. You're going to see a lot of the things we already talked about here in terms of using trusted sources and communicator, in terms of messaging that focus on responsibility and social norms and so forth, but really good practices. And the idea is that people can take this and whatever they are and use them sort of as a guideline for how to communicate effectively about that. It's evidence-based guidelines. Again, this should come out very soon. In terms of that, part of I had a chance to comment on that for them. Part of my hesitation with some of the recommendations was there were prescriptions. Use trusted sources. Who are the trusted sources in the community, right? They need to do some legwork to find out who these are. And so it's really important that you give some sort of guidance beyond just the prescriptions. We're all good about giving prescriptions, or we need some guidelines, clear guidance about how to do that. And then finally, I want to alert you. So, because we understand that not everybody is rich universally, particularly elderly and some other groups, we see an important role for the news media in being a knowledge broker in this space, and particularly journalists. Journalists have a very, very important role in doing this. And so our own standing committee, the one that Bill and I are members of, is organizing an event, and I would hope you guys can join us on February 5th, where we provide some tips and ideas for journalists about how to cover the vaccination COVID-19. And there will be how do you deal with issues of equity, and talk about that. We also have specifically talking about how we engage, not simply report, but how we engage. Journalists also have an important role in telling us in the public health community what information is not out there. Tell me a story about the population you serve that will tell me what I can do to help them in terms of information gaps or capacity gaps and so forth. So you have a link here if you want to register, and I would invite you to do so. And I'm going to stop here and thank you so much for your attention, and happy to continue the conversation.
Great. Thank you very much, Itzhak, and thank all the speakers. What a great job. Do any of the speakers want to have a follow-up comment on what they heard in either before or after their own talk? Before we get to the Q&As?
I will. I'll say something provocative because, you know, that's who I am. I think our challenge in this country with this current epidemic and with this political nightmare that the country is facing has to do with is rooted in our educational system. We don't teach our children science. We don't teach our children civics. And so unless we change the way we operate with the new generations in schools, we're going to continue to have populations that don't understand how viruses work, that distrust vaccines, and who can't name the 3 branches of government. And I think that's a lot of the problem we're facing right now, is 2 generations that have come forward without that kind of education.
Thanks, Perry. That's very provocative. And I think that's one of the reasons that Bill, Mary, and I thought we needed a science communication initiative to bring together within Rutgers University people who are doing science communication in some manner, shape, or form. I've been a bench scientist for many, many years, and I was just amazed that there is no real effort or coordinated effort to bring science communication training into the curriculum of science programs at Rutgers. So that's really the mission, or part of the mission of the initiative. So thanks for that comment. Katya or Itzhak, any follow-up?
Go ahead, Katya.
I was going to say, I think we found a lot of common themes across the presentations. We largely agree on a lot of the angles that communication should try and take with regard to convincing people to get the vaccine. And I think one thing that is really important from what Itzhak said specifically is that we need to identify within communities, and I saw that was also, I think, a question in the chat, identifying, not only talking about trusted messengers for the vaccine, but actually helping people find out who those are, because that's the difficult part, just telling you, find out someone that everyone trusts and have them, you know, record a vaccine message is easy, but it's a lot more challenging to do that on a community by community basis. And I think both Perry and Itzhak were saying exactly that, part of what is so challenging about this is that there's going to not be universal solutions. Like whatever we tell each other in this conversation, there's not going to be one size fit all. And we are going to kind of have to dig deep and identify ways to approach this that might be vastly different across different communities, and hence the problems that we're encountering here. So yeah.
Can I just add something to what Katya said, because it's something very telling, I think, to our conversation. As we were sitting here, and you know, I was multitasking as I always am. I received a text message from a woman who I adopted a little Pekingese puppy from in December. Pictures available upon request. Her name is Charlotte. She's white and adorable. But anyway, she's in this small town of Alma, Georgia, right? And so she's become very close with me, and I've been communicating with her. And she just said, oh, I said, you know, Georgia, and her name is Georgia too. I said, you have to go get the vaccine. You had breast cancer, you are high risk, you know, you need to go get vaccinated. And she was like, really? And so I finally talked her into it. She went to her doctor today. The doctor said, well, let's do an antibody test first to see, and then you can determine if you're like, so when the physicians aren't giving like the information that's accurate, what we're like really in a challenge situation, because there's no reason if she has antibodies that she can't have the vaccine.
Yeah, and I think exactly what my point was is that this is fairly complex. I mean, you know, it's a complex behavioral problem to solve. And, you know, we typically use tools like social marketing. So again, make it easy to people, you know, communicate to them effectively. But one of the things I want to point out is that communication, if you think about communication strategy, you have 3 different roles here, just following on what Perry said. You know, the very basic one is to educate. Okay, you know, we have responsibility to use communication to educate different groups of public about the vaccination and about vaccine, right? Just to tell them, you know, so that by the way include those people who are ready to take the vaccine. It's not clear to me that they looked at information about vaccine. They just made the decision, okay? And so we want to make people informed decision. In addition to education, though, we need to recognize this group, particularly those who are hesitant, we need to use communication to influence. And we have tools in our arsenal that we use on a regular basis to communicate risk to people, to motivate behavior change. Behavior change communication falls into this category. It's certainly the kind of work I do. But in addition, you can use communication very effectively to remind people, right? I mean, you already agree that you want to do something. You're ready to be activated. All you need is tell me when and where, okay? And I'll do that. And if we start thinking about this kind of division of labor in terms of we need to have that kind of 3 dimensions and operate. And I think the last one I would add in is the importance of local. All health is local. So to some extent, we need to build capacity to communicate effectively. I find that some of the most effective communication I received around COVID-19 was from our local health department, who took the time to create infographics and took the time to share data about COVID incidents and where do you get vaccines and what's the plan and who's next and so forth. I found that, because we didn't give them any tools, they had to figure out how to do that. And we certainly can build the capacity to do a good job communicating around that.
Great.
Yeah, and one of these, I just have a small comment. One of the interesting things that we heard from people who create policies is that they were saying, how do we target the vaccine-resistant people? Like, how do we convince them to get vaccinated? And what Itzhak is saying is, can you please focus on people who actually want the vaccine and maybe on those who are hesitant for now because they can't even get it. And when you're done with them, maybe then, then refocus on the resistant groups, because even those who want to get the vaccine can't right now. So I need to tell them what to do and then go to the hesitant group. And then, after that, maybe the resistant.
Good. All great comments. Thank you. So there are a few questions from the audience. Let me just read some of them, and they may be directed at specific speakers, but some are toss-ups and anybody can chime in. So the first one is the misinformation on infertility with vaccines affecting women's perception of vaccine safety. I think this came early in the session and probably directed for Katya.
I think it's even more general than that. That could play a role with it, but women seem to be in general more hesitant with regard to some of those health interventions. And so we find that not only with COVID vaccines, but in other scenarios. So because they, in general, are more risk averse than men in many situations, and vaccines can be perceived as a risk. And because we had some miscommunications about the vaccines, where there was a period of time where the left was claiming that they were rushed and they might be problematic, that Trump might speed them up to get them before the election. And so this, I think, is still affecting people's thinking about the vaccines, and women being just more generally risk averse might have that pattern more strongly with regard to COVID vaccines if they perceive them as not being fully vetted and fully tested.
Can I add to something to what Katya said? Because I think here's our dilemma, right? So when you look at flu vaccination and you see hesitancy around flu vaccination, it's not the usual pattern we see with health disparities. We see those with more educational attainment avoiding vaccination than less educational attainment. Now let's fast forward to COVID-19. So now we have a population of people with medical mistrust, right, who tend to have, either because they have low levels of education or lower levels of education, and people have medical mistrust because of higher levels of education. So you're getting two groups, sort of putting pressure on the system that need very different ways of dealing with them. Like how you deal with Jenny McCarthy, and her anti-vaxxer nonsense is going to be very different than how you deal with, a 75-year-old, Black woman here in Newark. They are two different kinds of human beings. And so Itzhak and Katya, you said that also beautifully, targeted messaging. It's the reality for us.
And maybe I would add that obviously the challenge we have is this is a moving target. we just started to administer these vaccines, and we're going to have to track the long-term effects of these. We don't have all this information right now, and so if we're risking losing credibility if we come and just debunk these, and they turned out to be the truth, right? And I think that, that's part of the issue, is that in the way you communicate, and that can, again, that kind of message can resonate. People want certainty. Policymakers want certainty, but we need to tell them that the scientific process has to play its role, right? I mean, the only thing we can say is that right now we believe that the benefits of taking the vaccine outweigh the risks. But I think in general, part of the challenge from a science communication perspective is that this is a moving target. This keep evolving. We're learning. We're kind of building the plane as we go. Okay, we use the best evidence we have from previous. As Perry mentioned, it's not we come into this without any knowledge about how to communicate about vaccination. It's just that the science behind that is still evolving, and that's making it challenging to communicate.
Thanks. Here's a question. I'm a physician from a minority group, African-born, and a lot of people from my community are vaccine hesitant. They believe a lot of the myths cited already about vaccines and suspicious of targeted efforts to have them vaccinated. Many African immigrants also work in the healthcare, which is concerning regarding their exposure risk and transmission. What communication strategy would you recommend to target these groups?
So one of the things, we have experience with communicating with different population, right? And again, a lot of people use the how to reach. I personally prefer the difficult to engage. You can reach them, but you have to do so. Think about the kind of operation that Stacey Abrams has, for example, in Georgia, to get people to vote. And so it has to come from the community, I think, to some extent. We can help them build capacity, we can provide information and message, but it comes down to relationships, right? And I don't have the relationships, and I should not be communicating with them. But so I can be in the background, quite content doing that, and helping to provide information that they need. And I think part of the information is going to be important for many people, is that, particularly for the African Americans, because they are concerned about side effects, is information to address side effects, but also that social proof that you see many more people in your community take. If my own cousin took it, and the first thing I did, my siblings live in Israel, and as you know, Israel is way ahead of us in terms of vaccination. Both of my siblings who are younger than me and not at a risk group already got vaccinated. So the first thing I did is I gave them a phone call. They got the Pfizer, and said, "So how was it? Are you?" And we had a little bit of fever, not a big deal, but we feel just fine. Everything is fine. That kind of increases the confidence, right? That you can, these are people who are my flesh and blood. So if it works for them, should work for me. And I think that's a kind of proof that they may need.
Itzhak, you raise you speak to the diffusion of innovation sort of approach, right? Which is, we know from the HIV, I'm an old man, so like I've lived through the 80s, right? But like in the 80s and the 90s, when we wanted people to the 80s and 90s were great, by the way, Katya, just FYI. They were amazing.
I was around.
No, you weren't. They were, when we wanted people to have safer sex and use condoms, we used this diffusion of innovation approach, which was like, you brought people who were like the near peers, who are like the people who people trusted and looked up to, right? Who they had in close regard, right? And if they did it, then I did it. And so I think it's exactly right. You got to get people in the community who become these trusted individuals who are members of those communities, and they become the sort of the facilitators of vaccination uptake.
This is exactly what we find as well. And just one thing to add, which is to agree with someone who I think recently posted a comment in the chat, that physicians have a key role to play. So some of the people are going to be people that you know around you, but local physicians within a community have a super important role to play. So both educating them, persuading them, and having them serve as messengers, not just doctors in general, but your doctor specifically, a member of your community, that's going to be important as well.
Great. Another question, please comment on the issue of antibody-dependent enhancement and pathologic priming that was problematic in many prior SARS vaccine development efforts?
Nope.
Nope.
Harry?
Nope.
Okay,
I
sorry.
don't have that answer. I didn't do that homework. Sorry.
Here's one that's a little less specific. How will herd immunity work if 200 million people are vaccinated when we have 140 million who are not?
Yeah, so I do think what you saw the slides from all of us that we're moving in a direction where I think we can get to 200 million. So, you know, the country, 200 million, and I'm thinking also when I'm doing those numbers, like I'm thinking 18 and over, right, is really the population that we're going after here. So eventually we'll work with the children too. There will probably be, we all know that these vaccines are going to be iterations of them moving forward, right? When polio vaccine first came out, it was a live vaccine that was given, and then it was not a live vaccine put on sugar cubes that I took in school, that they gave me on a sugar cube. And like, you know, that was amazing. We're going to get to that too eventually, right? But I think we can get, I think if we have enough vaccine, we can get to the herd immunity of 200 million people by the fall.
The other thing is, as I'm coming at this, I'm not an epidemiologist, so if you ask me about antibodies, I don't know anything about that, but I don't know about diffusion and contagion because I'm a network scholar. So it matters quite a lot who the people are who you vaccinate first. So it's not just about having, 50 million people. You want to vaccinate the people who are in high contact with others. And so having those medical professionals be vaccinated, given how much contact they have with COVID, is super important. Having people who sell you food at the supermarket vaccinated is super important. So people who are very central in that network of social interactions are, first of all, at a much higher risk. And second of all, have higher capacity to spread the virus. And so targeting them first is actually going to be helpful. And hopefully the people who remain towards the end, children, populations like that, they are perhaps less risky, not just in terms of getting the disease, but also in terms of spreading it around very much.
And I love myself, I'm sorry to interrupt. It's like, I love my healthcare providers, but if you saw the paper that just came out from California about mortality among workers, the people who are dying in there's a 22% increase in mortality in California during the beginning of the COVID pandemic, but who are dying? The supermarket workers, the agricultural workers, right? Those are the Amazon guy, the UPS guy. And we really need to get the vaccine to those folks because often those folks are also living not in 7,500 square foot palaces. They're often living in apartments that are crowded. And so there was issues I had with 1A for a while because it felt like a little unequitable to me.
And I was about to say that, the concern in public health is that, the vaccine is seen as a panacea, right? That somehow we get the vaccine and we're good. We don't have to put masks on. We don't have to keep social distancing. We don't have to wash our hands. And I think part of that will be a normative change. And one stakeholders group that have a lot to say here will be businesses and employers, because they have a way of enforcing this. So there's less resistant if a business owner telling you need to wear a mask than if, I don't know, President Biden is telling you to wear a mask, right? And so if you normalize this idea of wearing a mask, and I hope I'm not wrong because my data is not wrong, but we had a mild flu season in part because we're washing our hands and putting masks on. Who knew that we can fight the flu in this way? So I think part of that, the concern will be is that people are just okay. One of the things that happened in Israel, which is really, well, these are Israelis, so it's my old countrymen, but the minute they get a vaccine, they already buy tickets to go somewhere, right? Because it's cheap flights, and I can go, and I'm going to have this green passport that just said I got vaccinated, and they went to Dubai where they could do that, and then all came back with the UK variant, and now, of course, they have to close for the fourth time, despite making such a progress on vaccine. So the fact that people don't understand that you need to have the mental toughness that we're going to have to be responsible and disciplined until, in part because we want to protect our kids. There's no vaccination for children.
Right.
And so we need to take this very seriously.
I don't ever want to go forward. I think there's so many lessons here that we can't forget. Like, we should never go to a concert or a football game or a hockey game or whatever it is you go to. For me, it's going to be Taylor Swift, because I thank her for the both albums she released this year and making my life better. God bless her. But we're going to have to take people's temperature always, period. If we want to like contain diseases and we think people are infectious, they have fevers, that's one way. That's a public health approach. Now we have all these things set up in gyms and everything. Let's just make it normal that you walk in and you have your temperature taken.
Good point.
And that's the next thing I'm working on right now. The next report I'm working on has to do with norms and how accepting people are, say, being told that they need to be vaccinated to get on an airplane or go to school or do all of those things. And I think Itzhak is right. I'm still working with the preliminary data. That report won't be out until next week. But it seems that it is less, it's backfiring less where it's not the government telling people that they need to do it, but it's like an employer or a company. It's like some kind of a private actor that seems less invasive. So that's another thing of thinking about who is going to be enforcing vaccination norms, and if anyone is going to have those requirements, or whether we're all going to just count on each other to be good people and do that. Like, are we as instructors in a university going to have to get vaccinated or not? And is everyone going to get a vaccine at Rutgers? It's an interesting question.
There's from a communication strategy. I mean, you talked about a lot of target groups. One group that wasn't mentioned is people who have underlying medical conditions, in particular autoimmune diseases, where they're a little bit hesitant to tickle their immune system to a degree, especially in light of the cytokines you mentioned. How do we reach those or convince them that it's safe?
That's a great question. So, you know, I've worked with HIV positive people for 25 years. I'm about to start a study very soon to look at vaccine hesitancy in HIV positive people. It's really interesting because in some ways you have a group of people who've been traumatized by one thing, by one pandemic, getting traumatized by another pandemic. So it's going to be interesting to see how the patterns play out. I think that's a heavy lift, right? I think it's like, you know, there's going to be hesitancy there, and probably rightfully so among people who are immune compromised about the vaccine, because, you know, we're only, as Itzhak said, we're only beginning to learn how this disease manifests. If you asked me 3 months ago, are positive people affected more than HIV positive people affected more than the normal population, I would say, no, they probably have protection. Because one, they are on antivirals that probably are having a helpful effect, right? And we're not seeing mortality and morbidity at the rates we're seeing, you know, that we would expect them to see. Oh, but that just changed in the last 2 weeks when I find out that there's great cytokine thrombocytic purpura phenomenon that's going on because of the immune dysregulation. So it's Itzhak's point. Every day is a new piece of information. So I think we have to be honest with people. We don't know what this vaccination is going to do, but quite frankly, as a person who's done HIV work for like 25 years, I'll say this to you: we don't know what the antivirals are doing either, and people are taking antivirals every day to stay alive.
Okay, thank you. There's a couple of questions that are focused on Republicans and why they're less. Is it really due to Trump only? Was the question.
No. Politics shape public health. I actually just wrote an article about that. No, it's not just Trump only. There's a whole, there's a whole anti-science movement in on the extra conservative Republican Party, that doesn't believe in science as a means forward. And this is not new. Anyone who's followed the history of the Republican Party in this country can trace it back to 1968, the beginning of that conservative movement and the anti-science establishment. George Bush II was the one who said, oh, people liked him because people could have a beer with him. He wasn't this intellectual. And so the dumbing down of America right? And the anti-intellectual movement is very much part of the right-wing pattern of behavior, I think.
I think it's important to understand that there's actually organized strategy to recruit people to resist the vaccine. So, if you tie it to, it's kind of the linkages, if you tie this issue of vaccination, things like freedom and government overreach and some other kind of red flags that Republicans usually add, if you make that connection for them, right, and then they come to see that as an issue of impinging on my freedom and so forth, you expand your base, so to speak, right? You expand, and that's what the anti-vax has been doing. They've been using this kind of labels to attract, to bring people in, and develop that resistance, not based on medical anti-science necessarily, based on the fact that this is a government overreach. And you kind of saw that with this question that in the graph I presented about if it's going to become mandatory for you to get vaccinated, would you accept it or not? You can saw Republicans are far less likely to accept that if it's going to be mandatory. So there are coordinated efforts to engage this group in resistance, right? To build that kind of resistance. And then that's something that in addition to misinformation, we have to also emphasize. So we need to emphasize the fact that it's not about, again, it's not about politics. It's about, science, right? And really push that in. And again, one of the things that we need to remember is that part of the reason science still enjoy, I know we talk about how science is eroding, but science still enjoy, as is the military, some level of trust for most people compared to our other institutions. And part of the reason is because science has been successful. Science will get us out of this, right? It's the vaccine. And so to the extent that we're emphasizing success of science with, again, the caveats that things can change, I think that will move more and more people in that direction.
Yeah, so we find the exact same thing that Itzhak is talking about, which is that the primary driver there, one of the primary drivers is the sense that there is a government overreach and that Republicans actually do report trusting science and trusting doctors, less than Democrats, but in relatively high numbers, that there's not that many. So the problem is not just anti-vaxxers. They're not such a huge group. They're not such a huge group on the left, they're not such a huge group on the right, but with COVID in particular, this got extremely politicized as well. So that's a second factor that builds in on the first kind of lack of trust in the government. In a big government, which is that they were told by right-wing outlets and political actors that COVID is politicized and that it is overblown, that doctors are reporting more cases, that people that are suffering from other diseases are reported as having COVID or being dead from COVID, when that is not the case. So all that is floating around and making people think that the left is increasing the perceived influence of the pandemic for political purposes, which unfortunately is not true. And so that's also that's a COVID specific thing. COVID got more politicized than many other pandemics. Like if we remember the swine flu pandemic or anything like that, granted there weren't this big of a huge of a thing going on in the country, but it also weren't that vastly political in how people perceive them. And so I think that's kind of the pushback that you get from conservatives is partly because of this sense that they hear a lot of those messages. We're capturing some of those in our surveys that say, for example, that it's okay when people go to protest African Americans being shot by the police, that doesn't increase COVID, but when they're protesting election fraud, that's bad. So they're being told that basically the left is okay with some ways of responding to COVID that are politically expedient, but not others. And so that's why they perceive the whole pandemic as a really political issue. And that's why there's so much pushback, which is really, really unfortunate, because we're seeing, if we look at state by state data, which we are looking at the states that have the conservative population with the conservative governors are really struggling in a lot of ways because of some of those factors. So
I hate to interrupt and shorten the session, but we're getting near the end, and I want to give Bill Hallman an opportunity to close out the session. I want to thank all the speakers. Terrific, a lot of good information that we can use and build on. And Bill, you want to just say a few final words?
Sure. Thanks very much. What a fascinating conversation. I think it's just illustrative of the idea that we do have this very deep strain of expertise here at Rutgers in so many areas. And what we're trying to do with the Science Communication Initiative is to bring us together so that we can actually work synergistically on these kinds of problems. That's really the underlying reason for the initiative itself. If you've not joined the initiative, you can do that easily by going to scicom.rutgers.edu. That's 2 M's, scicom.rutgers.edu. And you can join us. Already there are about 40 or 45 faculty whose pictures and brief bios are on the website. If you have research projects going forward and you're looking for a science communication expert, you can find people on the website. Hopefully you will join us as well. We will have our next webinar focused on misinformation on February 23rd. You can also go to scicom.rutgers.edu for more information about that. And of course, if you sign up, you will get emails from us letting you know about each of these webinars each month. So again, thank you very, very much. I know that there were a lot of questions we didn't actually get to. I wanted to jump in with about a half a dozen of my own, so maybe we can connect offline. In the meantime, thanks again. Hopefully we'll see you all on February 23rd. Be well, be vaccinated. Cheers.
Bye. Bye, everybody.